All right, we'll go ahead and get started. Again, thank you for joining. This is the Value-Based Payment in the Tug Hill Seaway Region webinar. And then just to know, this is being recorded for those unable to join us today, and it will be available at a later point through the District 5 FastFacts. So quickly, if you do have questions, please feel free to type them in the chat box, and we will definitely get to them at the end of the presentation. So again, that's the chat box for any questions. All right, so my name is Lindsay Baldwin. I'm the Deputy Director at North Country Initiative. I oversee the district deliverables, the Delivery System Reform Incentive Payment Program for the NCI Performing Provider System, as well as provide oversight to the Regional Accountable Care Organization and the North Country Independent Practice Association. We also have Erica Colasino here today from United Healthcare. She is the Network Program Manager, and we'll hear from her later on in the presentation when she reviews the United Managed Medicaid Contracting Strategy. So the agenda for today's webinar, we'll first review the highlights of the New York State Value-Based Payment Roadmap, titled A Path Towards Value-Based Payment. We'll also go into the structure created within the Tug Hill Seaway region for value-based payment contracting. And then I'll also be standing in for Fidelis Care. They weren't able to join us today, but they did provide content so we can review the Managed Medicaid Contracting Strategy of Fidelis Care. And then, as I mentioned, we have Erica here today from United Healthcare, who will go into the Managed Medicaid Strategy for their organization. So first, as typical of the healthcare landscape, there's already been a number of acronyms. There'll be plenty more. So if you don't know all of these, by the end of the presentation, hopefully you do. So the Delivery System Reform Incentive Payment Program, that is the DSRIP program, or the 5-year program to reduce avoidable hospital use within the Medicaid program. That's coming up to an end this March of 2020. You'll see the acronym CBO, or Community-Based Organization, the CAG, or CAG, which is a Clinical Advisory Group, MCO, or Managed Care Organization, a lot of VBP, so value-based payment. Hopefully that one's familiar. We'll go into TCGP, which stands for Total Cost for General Population. And then the last two, IPA, Independent Practice Association, and ACO. I've already used those two. Those are the type of value-based payment contracting entity types. So we'll definitely get into all these acronyms today. So first, a review of the New York State Value-Based Payment Roadmap. Included in this slide, which again, they will be posted after the presentation, there is a most recent link to the roadmap. It is a redline version at this moment. It's the proposed 2019 roadmap that was updated and out for public comment of June this year. So first, what is the roadmap? This was a requirement of the district waiver with the federal government for the DOH to develop a roadmap for comprehensive payment reform, and that payment reform was through value-based contracting. And this was set up to ensure the long-term sustainability of the district investments through the district program. Within the roadmap, there's requirements as well as standards for best practices. I've included a few examples here. So for quality measures, for example, requirements have been set. So there is a requirement to have at least one Category 1 pay-for-performance quality measure in a value-based payment contract to be considered a value-based payment contract. And this measure must be used to determine shared savings or losses. In the most recent version, you'll see that there is a new proposal that there will be a requirement to have at least one Category 1 pay-for-performance measure from each of the 6 different category types. So those categories are integrated primary care, mental health, substance use, HIV and AIDS, maternity, and children. So outside those requirements to have the pay for performance measure within a value-based contract, the state does not enforce how MCOs and value-based contractors decide on things like the total number of quality measures in a contract or the specific measures that are included, including how performance will be measured. So whether it's a 10% gap to goal or if it's a percent of a statewide target. They don't set requirements for those types of things. Target budget setting is also covered. This topic area is strictly guidelines only. There's no requirements. And this is to assist managed care organizations and value-based contractors in negotiating those value-based arrangements. So it speaks to including potentially growth trends, historical costs, and risk adjustments in calculation of those target budgets. Inclusion of community organizations. This is an area where there is a requirement, and those in risk-based contracts, so we'll go into kind of risk versus no risk a little bit later, but those in risk contracts must include at least one Tier 1 community-based organization to address a social determinant of health. So I said Tier 1, so this isn't defined anywhere on the slide, but for those of you who may not know, a Tier 1 CBO is a non-Medicaid billing organization or community organization. And then, again, as I mentioned, we'll go in later to discuss further, but the roadmap does define the types of value-based payment as well as the levels for each of these arrangements. And just to note, the roadmap was designed to be a living document to incorporate lessons learned and best practices as the state unfolds kind of some of these arrangements in different areas of the state. So there was an original document developed in 2015, and the state does update this each year based on those items and lessons learned. So who develops the roadmap? There's been over 500 stakeholders from across the state, and this includes value-based payment work groups and subcommittees. You'll see the 4 different types of work groups that tackle technical design or addressing the financial and methodological policy questions, as well as some quality support and design policy questions. There's the regulatory impact, so those groups addressing the regulatory policies. The social determinants of health and community organizations. So the group put together to formulate and provide recommendations that drive value-based payment by addressing those social determinants of health, the training needs of CBOs, and to ensure that all the pertinent organizations are involved in contracting. And then you have the advocacy and engagement work group who assists in the design of member incentives to promote lifestyle choices proven to improve health and reduce costs of the members. So in addition to these work groups, there's also what we already kind of visited in those acronyms, the CAGs, or the Clinical Advisory Groups. So these were created to make recommendations to the state on quality measures, data, and support required for providers to be successful and address the implementation details to specific value-based payment arrangements. The CAGs were formed via nomination from the work groups and based on an individual's knowledge, clinical experience, geographic diversity, so whether they're from upstate or downstate, and total care knowledge. So there was a total of 7 CAGs that were developed. That would be maternity, physical health and chronic disease, behavioral health, HIV and AIDS, managed long-term care, intellectually and developmentally disabled, and then children's health. So these CAGs do continue to convene to review the measures for each of their categories. The measure sets do experience change, so that's deletions, additions, and modifications to ensure that they are capturing the key outcomes that matter to each of the groups. So why is the roadmap important? So payment reform, as I already mentioned, is essential to ensuring that the savings realized through the district program can be reinvested into the Medicaid delivery system. So support of integrated care, focusing on prevention and population health, and then the necessary infrastructure to support HIT. In addition, payment reform is intended to reward value over volume and support the predictive losses in the current structure, the fee-for-service revenue we are now familiar with, that we would look to reduce with reduced ED visits, admissions, and the other district-related outcomes that are affecting the payment system. So to ensure that MCOs and providers progress towards value-based payment, the state has set statewide goals related to value-based payment. So as of March 31st of 2020, all MCOs must have level 1 or higher value-based arrangements for at least 80% of their provider payments. Furthermore, at least 35% of those have to be in a level 2 or higher. So should these milestones not be met, the state will be applying penalties to the MCOs. And also to note, the movement to value-based payment aligns with the federal goals of the Department of Health and Human Services to pursue alternate payment models, which is a part of their goal number 1 in their most recent 2019 fiscal year annual performance plan. So then the levels of value-based payment are also, as I mentioned, defined in the roadmap. Technically, we've got 4 levels here, but only 3 of them, so level 1 through 3, are considered actual value-based payment arrangements when it comes to that 80% threshold that the state sets for MCOs and providers. But the level 0 is important. This is what is usually referred to as payer quality programs, or their bonuses paid by the MCOs to providers for reaching certain quality scores. But there's no consideration to cost at that level. Then you get up to level 2, where the fee-for-service structure still remains, but the provider or group of providers, so if there was a group of providers in an IPA or an ACO, for instance, they have to reach a certain quality score and hit a benchmark for cost. And then if they were able to do so successfully and save costs, they would share in that savings. But then should the cost of care increase, so losses would be generated in a level 1, the providers are not at risk for sharing in those losses. Whereas when you go up to a level 2, similarly, the fee-for-service structure still remains, but as I mentioned, we'll have the quality and benchmark, but then if shared savings are not realized, the providers would be subject to share in the loss should it occur. Of course, if there is savings, they would share in those savings as well. And then finally, when you get up to a level 3, this may be also known as capitation. This is the level where the fee-for-service infrastructure doesn't exist anymore, and it's a per member per month, or PMPM payment to providers, and they have to manage their population given their PMPM amount. So should a population cost come in under the total PMPM payments, then the providers would keep all of that shared savings. However, should the population cost exceed those PMPM payments, then 100% of the losses would be absorbed by the provider. So then when you look at types of value-based payment, there's 2 different buckets, really, population-based and then bundle or episode-based. The population-based includes that TCGP, or total cost for general population arrangement, and this is where you contract for the total care and cost of the included members. But typically in these arrangements, they will exclude special populations such as HARP members or managed long-term care, and that's what can spin off for those total care for subpopulation arrangements. The opportunity currently exists in our region for this total cost for general population arrangements, and when reviewing the population side within the region's subpopulations, there's really not enough lives to effectively manage a value-based arrangement. since there would not be enough opportunity to demonstrate improved cost or quality given the small population sizes in those subpopulations. And then there's those bundled or episode-based care arrangements, and these arrangements, they have to have a clear start and end date. So a popular example that's typically used is maternity care. So there would be a time frame again. So typically that's from pregnancy through delivery, including 60 days postpartum for the mother, and then the first month of a baby's care. So the target cost of this episode would be set in this type of arrangement, and then if a provider were to come in above or below that target cost, either savings or losses would be generated, and depending on the level, so either 1 or 2, those losses may or may not be shared, and then the savings would be shared. With the goal of having 80% of total managed care organization expenditures in the level 1 or higher arrangement by March of 2020, currently we're seeing MCOs pursuing the population-based arrangements since they are lending more towards meeting this goal. And while a member can't be counted in 2 different types of arrangements, there is a potential for contracting combinations should it make sense for that region. For example, a total cost for general population arrangement may have the opportunity to carve out the cost of maternity care should there be a negotiated maternity episode-based care arrangement for that same population. So definitely some opportunities to have a more comprehensive type arrangement should it make sense for the region. So then the roadmap does define as a requirement that MCOs contract with value-based payment contractors. So this is a legal contracting entity such as ACOs, IPAs, or individual providers. I would note that PPSs, or performing provider systems, are not in their current structure legal contracting entities. Therefore, to ensure the Tug Hill Seaway region had that structure in place to contract with MCOs, the North Country IPA was formed about a year ago. So I am going to go into that structure so you know how this region has set itself up to be able to enter into these types of value-based arrangements. So the North Country IPA is a contracting entity formed from the 6 NCI hospital partners. It is led by a 25-member physician-led board of managers. That's 19 providers or physicians, and it includes behavioral health representation. The IPA is a messenger model. So what that means is that partners can sign into the IPA and be members of the IPA, but they maintain their own control to either opt in or out of certain contracts that the IPA negotiates with payers. Participation agreements were signed by 21 partners throughout Jefferson, Lewis, and St. Lawrence counties, including 6 hospitals, 1 F2HC, 9 independent primary care offices, which includes 3 pediatric offices, as well as 5 community-based behavioral health entities. The IPA has been in negotiations with payers since its inception, most actively with the 2 primary managed Medicaid care organizations in the region, United Healthcare and Fidelis Care. We're still working to get to acceptable or agreeable contract terms for those total cost of general population arrangements. And one thing I would note here is the current structure as we're seeing it, well, may be subject to change, but in its current state, the attribution is given to primary care providers. So for those of you who aren't familiar with what attribution means, it's the method for which payers assign a beneficiary to a given organization. So in this case, the MCOs assign the members to a primary care provider who would be tagged as responsible for that patient in a value-based arrangement. However, the IPA does recognize that a beneficiary's total cost and quality of care comes from the entire care continuum and not just that MCO assigned primary care provider. So that is why the IPA has proactively included behavioral health providers in the IPA. So we do ensure alignment with value-based initiatives with the total care continuum. The purpose of the IPA is to ensure the structure to support the region in meeting the statewide goal of districts to have 80% of provider payments in at least a level 1 arrangement by March of 2020. And again, this is to support the sustainability of the district program through payment reform. The benefit of an IPA structure versus a provider contracting on their own into value-based arrangements would be the ability to collectively negotiate arrangements with payers as a group, and not only for managed Medicaid, but also for managed Medicare and commercial payers as well. In addition, the IPA has the expertise in clinical quality measures, EHR reporting, and data analytics to help providers maximize existing level 0 quality programs with payers, and then as we get into higher levels of contracting to support those contracts as well. So while the region now has the infrastructure to support success in value-based payment, which was gained through the district program, as well as now this legal entity to contract with payers, it's imperative to also have the payers at the table working towards common goals with our region. So that's why we've engaged with both Fidelis Care and United to present their managed Medicaid contracting strategies today. And as I mentioned in the beginning, Fidelis Care was unable to have a representative here today, but they did provide the content and talking points for me to discuss with the group. So first, they shared their 2019 models for contracting. They did want us to recognize that their programs continue to evolve. They've had experience from across the state and are working towards models in 2020 that would get them to their district requirements of having, again, that 80% of provider payments in level 1 and at least 35% in level 2. So they are assessing this currently, but it is a great depiction of what they've used to date. So they do have different models depending on the number of lives, distinguishing between greater than 10,000 and then a 5 to 10,000 lives. So again, you'll see the benefits of contracting together as a group in an IPA and an ACO versus maybe just doing it on your own with a smaller population size. So in their template contracts, they would share that 40% of savings should it be generated in a level 1 arrangement. And you'll notice in that group of less than 10,000, they do implement a cap of the amount of savings that could potentially be generated. But then when you go to level 2, you'll see there's a greater opportunity to share in savings. While not defined, it's expected that that would be more than that 40% of the than you see in a level 1. However, there would be that addition that there'd be a share in loss should that be occurred of 20%. They did share 2 other models. However, they are not currently being discussed for our region. So once in a value-based payment arrangement, Fidelis has an in-depth data strategy and approach that they would implement with the IPA. This includes access to a 3M data platform, and that allows providers to track their performance on quality and cost. It's expected that Fidelis arrangement would include 3M specific measures. As you see, they're utilizing their platform. And those measures are common if you are involved in the district program, things such as potentially preventable ED visits or potentially preventable readmissions are 3M specific measures. In addition, you'll see there's 2 other opportunities for data extraction and reporting. So either ad hoc reports that are not on the dashboard or raw claims data. So an IPA or ACO could import that data into their own warehouse for analysis. Then Fidelis shared the flow of funds that would be expected. So first, the DOH payment to MCOs for their premiums for the program members, and then the MCO to contract. In this case, you'll see circled the IPA or the ACO. And then it would be up to the IPA or ACO to have a distribution model in place to distribute any savings or losses to the various providers within the network. So this would be specific only to those shared savings arrangements. Any quality programs or level 0 value-based arrangements that the plan has through directly with providers, that funds flow would remain from the MCO or Fidelis Care directly with that provider, again, just for those quality programs. And then finally, this is specific to their quality programs. Fidelis has provided the following information should any providers have questions on the existing program. Fidelis does have provider relations representatives for our regional partners, as well as a provider portal for those participating in their existing program. So please, again, these slides are going to be sent out. Reference the links within this slide for additional information. So now it is the United Healthcare Managed Medicaid Strategy portion. I'm going to turn this over to Erica to go through their slides. So Erica, I believe you're able to now speak. You're unmuted. Do you want to give it a try? I can advance your slides.
Yeah, thank you. Can you hear me?
We can.
Okay, great. Thanks, Lindsay. Okay, so we're not able to publicly share quite as many details. It's kind of proprietary information about our contract specifics, but I can share our overall VBC strategy with everybody. So here on this first slide, this is what I'll call our model for the risk continuum, summarizing our TCGP models for VBC levels 0 through 3. At level 0, some of you may already be familiar with this, our CP-PCPI program, which is our community plan primary care physician incentive program, which incentivizes providers to raise their quality scores by closing gaps, HEDIS gaps in care. And then we have our level 1, which is our ACSS contract, Accountable Care Shared Savings contract, which are modeled on an aggregation strategy with smaller unaffiliated practices for shared savings only. At level 2, we have what's called our ACSR, or Accountable Care Shared Risk contracts, which are individual contracts with larger providers, health systems, IPAs, and ACOs. And then lastly, for level 3, we are currently in discussions with 2 downstate IPAs for the innovator model, which is a global capitation model with some services being delegated to the IPAs. That's something that I'll be working very closely on in the coming months and well into 2020. We can go to the next slide. Thanks. So here we have an illustration of our ACO support model, and I'll pause here to say that ACO I find is one of those terms that kind of depending on the audience or the presenter, it's sometimes used very specifically and then sometimes it's used more broadly. As Lindsay mentioned earlier, in NCI's case for Medicaid managed care contracting, the structure is that of an IPA, not really an ACO in kind of the traditional sense. So for this purposes of this slide, you could basically just substitute ACO for IPA here. And as you'll see, there's what we call an activation team dedicated to support the success of our relationships with our contracted ACOs and IPAs. It's made up of a clinical transformation consultant, or what we call CTCs, someone from our healthcare economics team, an account manager, and our market medical director. The CTC is listed as the day-to-day contact here, but really everyone on the team is available to the ACO or IPA. But the CTC is probably the person contacted most frequently since they're really responsible for providing ongoing clinical support to the IPA. but it's clearly a very robust, diverse, and knowledgeable team. So you're always in very good hands with this team. We can go to the next slide. So in addition to supporting our providers with a dedicated team of subject matter experts, we also provide support through data sharing, which is especially important and an integral part of any successful value-based contracting relationship. Everyone needs the data in order to determine what's working and what needs more work. So UHC sends all of our contracted VBC providers a monthly report called a PCOR, or a Patient Care Opportunity Report. That report points out things like gaps in care. It contains clinical data to help providers successfully do population health management, and it tracks performance on the specific incentive targets included in the contract. We also send providers in risk-sharing arrangements, claims files, and risk score reports, which show a practice things like risk scores of their members and potential coding opportunities. We can go to the next slide. Thanks. And then lastly, I wanted to share some important contact information for UHC. Many of you may already be familiar with your provider advocate assigned to your county, but if not, here they are. We have Chris Bennett handling both Jefferson and Lewis counties, and then Ashley Steele handling St. Lawrence County. If anyone needs the email addresses or phone numbers for Chris or Ashley, please feel free to let me know, and I can pass that information along to you. I've also included the address of our provider website, which is a really great resource. It houses lots of information about United Healthcare, kind of generally. It also includes some of our policy and procedure information, benefit information. It's a great tool, but then you do always have access to your provider advocates for any questions that you might have. And I've included my contact here, my contact information as well. Right now, I am 100% dedicated to DSRIP. So I kind of have a program manager role, which means I'm for the upstate PPSs, I'm kind of the first point of contact at United Healthcare. But I'll be getting more into actual value-based contracting probably over the next several months. But even though I'm dedicated to DSRIP, I'm always more than happy to field any questions that you might have and try to get you to the right person or department for any questions that might come up. And I'm always willing to travel if needed for any meetings or presentations. I'm here in the Albany area, and I work from home, and I'm mobile and can always come out if it's better to have someone there in person. I'm happy to do that. Thanks, Lindsay.
Perfect. Thank you so much, Eric. I appreciate you being on today and sharing United's managed Medicaid strategy. So we're looking at the chat. This does conclude the presentation. There's no questions yet. Maybe I'll give it a couple minutes. If you do have questions for myself or Erica, please feel free to type them in the chat area now, and we will reconvene here in a minute or two and address those questions. So we do have just the one question for the moment, and Erica, I might pass this one over to you, and it might require some follow-up, but how can we get the MCOs to provide reports that can be analyzed? The PCOR, for example, has great information, but is only good for reading, and a lot of manual work goes on to create analytics or share information with different parts of the organization. Erica, would you be able to take that?
I'm more than happy to. I think I would probably want to dig into that question a little bit more, just to get some more specifics to see if there may be a report that exists today that might be able to give the person asking the question what they need. We probably have just as many reports as we have acronyms, so I'm not familiar with all of them, but I can certainly dig into that a little bit more and see what it is that the person is looking for, and then to see if we do have some reports that we can provide to them that they're not getting today.
Okay, perfect. So I left your contact information on the screen. So, yep, perfect. If you can go ahead and send Erica an email, that would be great. All right, it looks like that was the only questions we did have. So again, this has been recorded. We will post the slides and the recording. It'll be through a District 5 Fast Fax. We will include slides with my information, Erica's, and then Fidelis Care point of contact information as well. So please feel free to reach out if there's additional questions. But thank you all for joining us today.
Thanks.